Welcome to Chapter 3. In Chapter 3, we dive into this idea of epidemiology, the study of disease, injury, and death in the community. So I want to say to hang on tight for this. And so while there may be a lot of terms in this chapter, I'm going to do my best to keep the ones that I think are most significant and try to break them down the best way that I know how. And I actually think that a lot of these terms you're going to be familiar with because a lot of these came up in the recent pandemic that we are still in the midst of, but feels like we're coming out of here in 2022. So list some disease that caused epidemics in the past and some that are causing epidemics today. We're going to discuss how the practice of epidemiology has changed since the days of Benjamin Rush and John Snow, and explain why rates are important in epidemiology and the commonly used rates. So continuing on, we're going to define the incidence and prevalence rates. We're going to discuss the importance of disease reporting to a community's health and summarize the following standard measurements of health status: life expectancy, years of potential life lost, disability adjusted life years, and health-related life expectancy. Identify sources of secondary data used by epidemiologists. Describe two main types of epidemiological, actually we're not going to do the studies. And then we're going to list the criteria used to evaluate whether or not a risk factor causes a disease. All right, so let's start at the beginning here. So epidemiology is population medicine. If the doctor works on the individual person, and that's what they're concerned about, the individual. When you go see them, you want them to be concerned about you. The epidemiologist is concerned about the entire group. They're like a macro doctor, if that helps you understand it. So an epidemiologist is concerned with the course of disease in a population. What is the outcomes of the disease? Where did this disease come from? What starts it? What prevents it? What allows it to keep going in some people while it stops in others? They're going to collect information about disease status of a community. How many people in the community have that disease? Who are those people? Are they old? Are they young? Are they women? Are they men? When did they become sick? Were they doing a certain activity? Are they living in a certain neighborhood? Did they have anything coming? Did they have any kind of preconditions? Like did they have trouble sleeping, or were they obese? Things like that. Data that can be used to prevent disease outbreaks and determine effectiveness of prevention efforts. In many ways, I think of them as being like a detective trying to understand what is going on that causes a disease to pop up to begin with, and then what causes it to be more impactful for some groups versus the others. Because if you can figure that out, then you can say, okay, well, let's spread the wellness that certain groups have to the other groups. Epidemiology is the study of distribution, how it's distributed throughout a group, and the determinants of health-related states or events in specific population, and the application of this study to control health problems. For many of the diseases that we actually understand today, like lung cancer, like heart disease, these things were not well understood before epidemiology looked at them. Why was it that heart disease 100 years ago was killing so many more people than it is today? Why is it that AIDS was killing off large sections of gay men? And epidemiologists began to study this sort of thing and came up with the understanding that we have today, which ends up saving lots of people's lives and prevents lots of diseases from popping up. So an epidemiologist is just one who practices epidemiology, be it doctor or other health professional. All right, let's talk about an epidemic. An epidemic is a unexpectedly large number of cases of an illness, and it is unexpected because there are some illnesses like the common cold and cancer and whatever that we kind of understood, and that's going to affect these number of people usually. But if it's an unexpectedly large number of cases, then you potentially have an epidemic of a specific health-related behavior or an event in a particular population. And the key there is particular population, because if it is over a large geographic area, and I think some of this is opinion based, like what's the real difference between an epidemic and a pandemic? Well, it's sometimes like you could split hairs, but with the coronavirus, you could say, all right, it was a pandemic. Why? Well, because it affected every country in the world, right? So pan, means to, what does it mean? Pan is a prefix that means large, reaching, or something related to that. An outbreak is similar to an epidemic, except that it is used for more limited geographic areas. So oftentimes there are outbreaks of certain diseases in certain areas, and people get really scared because oftentimes they're really scary, like they're killing a lot of people really quickly, but then it doesn't seem to leave that geographic area. I remember there was a disease in Africa that they were really, really scared of, and I remember reading a fictional book that was based upon it, but it never left that particular area. So that would be an example of an outbreak. An endemic is a disease that occurs at an expected level in a population in a certain location. A disease that occurs at an expected level in a population or in a certain location. So I guess you could include things like the common cold here. We now have expectations that it is going to impact certain numbers of people in certain ways, among elderly people, among children, and as long as it stays within our expectations, then it's going to remain an endemic. Let's talk about the history of epidemiology for a minute. Hippocrates, who was alive about 300 years before the birth of Jesus, he believed in a link between the environment and the occurrence of disease. That he said, like, maybe there's something going on outside of the person that is causing the disease in the area that they're around. And think about, like, the water or the air or the soil or something related to that. Unfortunately, after the Greek and Roman empires fell, we kind of went away from studying science or pre-scientific thought. The Greeks and the Romans really pushed us forward in terms of our understanding of the world, and then after those empires fell, at least in Europe, we went into what they call the Dark Ages, and so it was like out of the light of education back into superstition and those sort of things. The Arab world picked up some of that slack for a while, but the theories at that point were that people got sick because of bad air and the rotting food or miasmas. And so because they were not moving things forward after the fall of the Roman and Greek Empire, there were subsequent waves of infections, epidemics such as the plague, and they would happen and they would come in and kill a bunch of people, and then they would leave, and there wasn't a whole lot of understanding of why it happened, and so another one would come and kill a bunch of people, and so without really having much without much understanding of what was going on, until John Snow and some people like him who began to say, well, wait a minute, maybe we can understand things a bit more. They rejected the ideas of the day and said, John Snow, who was really ahead of his time, and we talked about him, I think, 2 chapters ago, and he wanted to do kind of a natural experiment where he wanted to shut off the water in this pump in the middle of London. And when they did that, then the epidemic stopped. Well, in order to really understand why something is happening, you really have to understand who it's affecting and understand numbers, or we might say statistics, because it's rare that everybody gets the disease or the health problem all the time. And it's rarely simple to understand why certain people get it and while other people don't. You could think, most recently of the pandemic that we are still in the midst of in some ways, and ask, like, why did some people get it, why other people didn't? Why did some people get it and it seemed like nothing happened to them, while other people it took their life? And so that's why rates are really important. It allows for a comparison of the outbreak at different times or in different places. And the cases are a term that refers to people who are sick. The rates are a number of events in a given population over a given period of time or a given point in time. So the number of events, how many people are getting sick over a 1-year period, right? Or if there was an outbreak, in July, then that would be the time. Like, how many people got sick? But you also could look at not just sickness, which is the fancy term for that is morbidity. You also could think about it as other events, such as people giving birth, or people dying, which is fatality, mortality. I guess both of those terms refer to deaths. A population at risk is a term that refers to people that are susceptible to a particular disease or a condition. So for instance, prostate cancer is only going to affect men, right? They're the population at risk, and the populations that is most at risk is older men. We're talking here about rates, and the reason why we're talking about rates is that we're trying to have language to help us understand how much of a problem this is, when did this change. And so when it comes to something like an incident rate is going to refer to the number of new health-related events of a disease. So sometimes a disease has always been affecting a certain number of people in a city, but now that number is doubled. It went from 1,000 to 2,000. Well, that extra 1,000 people who normally don't have it, you normally have 1,000 every year, let's say, but now you've got 2,000. That extra 1,000, that's the incidence. And so if you take that 1,000 and divide it by the total number of people who are at risk, you'd have an incident rates. But realize that it's the extra that's not normally seen. So if normally you have 100 people a year going to the hospital for the flu, and now you've got 200 people a year going to the hospital for the flu. Like, something dramatic has happened because you've just doubled the number of people who are having major health risks, and that is what you want to know. If you just said it was 200, it's like, well, is that a lot? Is that a little? So you'd want to know the incidence rate. It turns out it's actually a lot, right? It's important in studying of acute diseases. Acute diseases are diseases which peak in severity of symptoms within a few days or weeks, right? So typically they talk about diseases as two types: acute diseases and chronic diseases. Acute diseases are those that occur and then go away within days or weeks. It doesn't mean that they're not deadly, by the way. That we used to mostly die of acute diseases. It's just that we've gotten pretty good at treating those. The attack rate is different from the incident rates because it is calculated for a particular population of a single disease outbreak. Okay, so let's say that there's a plane that takes off from New York City and goes to Philadelphia, and in that plane, half of the people come down with a virus, right? So that would be an attack rate, because you would look at, how many people were on the plane. Well, there was 100, and then how many people got the disease? Well, there was 50 of them, so now the attack rate is 50%. And what if you wanted a number to represent the number of new cases of the disease plus the number of old cases of the disease over the last year? Well, that's the prevalence rate. So that alone doesn't tell you as much unless you knew the prevalence rate at the time period before that, right? So useful in studying chronic disease. Again, chronic disease is 3 months or longer. All right, we have some math formulas here. To distinguish between an incidence rate or incidence cases and prevalence rate, you could think of it like a bathtub, where you have water in the bathtub, and that represents the total number of cases of a disease, both the new ones, which here are represented as the incidence cases because there's new water flowing into the tub, adding to the prevalence cases, right? And then there's water flowing out of the tub either by death or by recovery from those. So total cases are prevalence and the new cases are the incidence. All right, and so just in case you weren't confused yet, we got to go a little bit deeper and now begin talking about these rates in new ways. So imagine that there's a high incidence of chickenpox among children. Okay, so children with chickenpox. All right. Incidence and prevalence rates are expressed as crude or as adjusted. Okay, so we can talk about the incidence, which would be the new cases of chickenpox that may be occurring in your state, right? And then you can talk about the prevalence rate, meaning like there's always people with chickenpox. Well, chickenpox is not a great example. And why isn't it a good example? Because chickenpox is not a chronic disease, right? So if we're talking about incidence, it's better to talk about acute diseases like chickenpox, by the way. But when we talk about prevalence rates, it's better to talk about things like heart disease or diabetes, or things that are harder to get rid of. They last a long time. So, okay. The crude, right, so we can express these as crude or adjusted, right? So let's stick with our incidence of chickenpox. The crude rate would make the incidence of chickenpox seem small, even if it was twice the normal amount, right? Because the crude rate is a rate in which the denominator includes the total population, right? And children, I don't know how much of a percent of the population they make up, let's say 20%. And so even if you had a lot more children with chickenpox than you normally do, I mean, even if if it was, let's say that it was, we'll keep the math really easy here. So if children make up 20% of the population and half of them have chickenpox, which would just be a crazy amount, then we would say 10% of the total population has chickenpox, right? That would be the crude rate, because you have 10% of the total. That doesn't necessarily like tell you a lot of information. Like, you're like, is that a lot? It's only 1 out of 10, But if you said if you made it an adjusted rate, so you made it age adjusted, where we're only talking about people in the risk groups, right? Then we're talking about, oh wow, now we have a 50% age adjusted rate. So it would just, that number would stand out and be much more significant. So how do we know all of this information in terms of things like, well, how would you know what the incidence rate was? And even if you know the total number of people who had the disease, you're going to have to know the total population. And so this comes from various places. We're going to start here with talking about physicians, clinics, and hospitals, and they're required to report the births, the deaths, and certain diseases that are reportable and notifiable as according to a list that they are given. There's a list there in our book, and those are diseases that there's a health concern around, or the state says we want to know how many people have these diseases. The usually notifiable diseases are ones in which there's something that needs to be watched. We need to, especially those that are contagious, where the CDC and other epidemiological groups are saying, like, these are ones that we really need to make sure we understand how many people have these, because if the rates change dramatically, then we need to make sure that we're not endangering the population. So unfortunately, sometimes the diseases, the ones that are notifiable, are for one group of people isn't the same as the other. So I feel like we might have talked about this in 2 chapters ago, but in terms of the way the data, the information is supposed to flow, remember this is the information we just talked about, on the notifiable diseases and things like that. The doctors, the clinics, the hospitals, they report that information to the local health department. The local health department passes that on to the state health department, which then kicks back a report to the local health department so they know within their whole state what is going on, and probably also within the federal government as well, because the state governments are going to be passing that data along to the Centers for Disease Control and Prevention, who is going to be kicking back to them a weekly report and summary of what's going on. They then going to pass that down to the local health department. The CDC is going to be passing data on to the World Health Organization. All right, the standard measurements of health and status of a population. Right? So sometimes it's interesting when I look at other countries and wonder, like, what's life like on these places. At the moment, I find Latin America kind of an interesting place, and I want to know, like, how healthy are these people? What's going on with their health and their money and things like that. And so in terms of trying to understand their health, that's what we're talking about here. There are some standardized measurements of health, and those include things like the mortality statistics. How many people had died last year? That would be an example of a mortality statistic, right? And how long are people expected to live when they're born? Life expectancy usually is calculated for infants. It's not really calculated very well for people who are not infants. I mean, they try to do that a little bit, but it's really, when they say life expectancy, they really are talking about infants and how long those are expected to live. So, and then you can talk about years of potential life lost, and this would especially relate to a disease that kills somebody. So when COVID-19 was really, hang on one second. All right, sorry about that. My cat was trying to get my attention. When someone has a disease that takes their life, then if they're young, then sometimes you can think about years of potential life lost and what this disease, the number of years that it cost that person. And if the disease merely disables that person, then sometimes they will calculate the disability adjusted life years. And this, you might ask, well, when would they ever use this in practical terms? Sometimes if people are going to court and they're suing somebody, maybe the person did something to somebody and it caused them to either lose their life or it caused them to be disabled, they'll use these calculators as a way of saying, life was taken away from somebody and we're going to calculate what that amount was so that if there are survivors, then those people will be paid out according to these calculations. All right, mortality statistics. This is the most reliable measure of population health status. Again, mortality statistics are going to be how many people died in a certain year. And it varies greatly depending upon age. That wouldn't be a surprise, but sometimes it crops up in ways that we wouldn't necessarily expect. So for instance, mortality statistics are higher in Florida than they are in Colorado, right? Now you might say, wow, what's so deadly about being in Florida? Well, nothing especially other than the alligators, but those aren't killing many people. What the issue is that age is so much greater, the average age is so much greater in Florida than it is in Colorado. Colorado is a fairly young state. Florida is where a lot of older people go to retire. So you would expect that the mortality rates would be much higher there than they would be in a younger state. Well, what about sex? Well, women tend to live in the United States about 3 or 4 years longer than men. People of color in the United States do not live as long as people of, well, usually you call them white people, but I typically call them people of European ancestry. Why is that? Well, that is because if you look at things like income and who has health insurance, it tends to be that people of color have less of that. And so that translates into having higher mortality, right? Ethnicity. There's a shift in leading causes of death since the beginning of the 20th century. So since the 1900s, early 1900s, we've shifted from acute diseases, things that killed us within, I think it was 3 weeks, to things that now may take years, maybe even take decades to kill us, like heart disease and diabetes and cancer. And those have been the things that are killing most of us now that we've gotten pretty good at treating acute diseases through things like vaccines and even washing our hands well and having things being sterilized. And that's all I could think of right now. Life expectancy. The average number of years from a specific cohort is projected to live from the given point in time, right? We mentioned this already. Typically, when you talk about life expectancy, it's from infancy. Health statisticians usually are concerned with life expectancy at birth from age 65 and age 75. Okay, so I was a little off here. I mentioned at birth. But they're also interested in looking at people around 65, which is the time when people transition from being an adult to being an elderly person. And then at 75, which is the age in which somebody transitions from being a middle old person to an old person. So it's not necessarily a useful prediction of any one individual, and it does not describe quality of life. And so from a person-to-person perspective, your life expectancy is not necessarily like an accurate way of predicting how long you're going to live. So I was born in 1980, and so like the life expectancy then for men was 76, and so I should not necessarily just expect to live to be 76 because it's an average. If it's me and 1,000 other men who were born in 1980, well, now it's a useful, but just for one person, not so much. And it also does not describe quality of life, which is another thing that is interesting about our healthcare. We've gotten really good at keeping people alive, but we oftentimes don't think about the quality of life. So People can be alive because we have amazing life-saving treatment, but that doesn't mean that they will be able to eat or that they will be able to control their bowels. And so this is a difficult thing to think about. Like, do you go ahead and get the next treatment, but that will keep you alive, but it may not increase your quality of life. In fact, it actually might decrease your quality of life. And so, but we feel compelled to get the treatment. And so it becomes kind of this new question about, when do we stop treatment? At what point do we kind of let nature kind of have its way with us? All right, life expectancy at birth, at 65 years of age, and at 75 years of age, according to sex. So let's see if I can get a marker here. And so let's start here in the year 1900. And so what you can see here is that life expectancy at 1900 was about 47 years, a little bit more for women and a little bit less for men, right? But if they managed to live to be 65, which is, by the way, quite a bit older than 47, right? Then men were still expected to live another 11 years, and women another 12 years. So the longer you live, the longer you're expected to live. So let's jump forward here to 2008. Now we have life expectancy at 78 years, actually almost 79 years. Again, a little bit less for men, a little bit more for women. And then if you look at them at 65 years of age, which is what, 12 years away from 78, they're still expected to live 19 more years in that. If you look at them at 75 years old, which, according to this life expectancy is about 3 years away, they're still expected to live 12 more years for that. So, years of potential life lost. This is the number of years lost when death occurs before one's life expectancy. Okay, so that's kind of like a simple math question there. And obviously, the bigger that number, the younger the person is, because let's say like a fairly young person who maybe is in their 20s, that person's loss of life, number of years lost, is going to be greater than somebody who's, say, 74. All right. The disability adjusted life years. This measures the burden of disease, right? One lost year of healthy life, right? So you look at maybe diseases that disable people. Maybe it doesn't kill people, but if it disables them, then you can say, well, how do you measure the impact of this? Well, you can measure this by disability adjusted years of life. So, and then health adjusted life expectancy, which looks at the number of years of healthy life expected in a given population or average. And so I think this is probably something that's really, again, I mentioned this earlier, that is probably not given enough attention. It is, it's not my place or really anybody else's place to say to somebody, if you're not healthy, then your life doesn't have meaning. That's not what I'm trying to say at all. But what I am saying is that we have these amazing tools that can keep us alive for longer than we've ever been able to, and yet it may keep us alive at the expense of our, not the expense of our health. It's going to keep us alive, but we may not be healthy. Right? So most people, when they think about dying, let's say at 80 years old, they think about the fact that they're going to be, living a healthy life up until they are 78, 79 years old, and then something happens, a heart attack, or they get sick, and then within a matter of 8 or 9 months, they're passing away. But that is not the experience of many Americans. Many Americans they're hitting 50s and they're having high blood pressure, and they're in the 60s and they have cholesterol and diabetes problems, and then they are 70s and now they are really having trouble doing the activities that they really appreciate, and they maybe diagnosed with significant health issues, but they're receiving treatment for that. Maybe they're on dialysis or they're having heart surgeries, and they're not being brought back up to health, but they are kept alive, and there's not like a conversation that's happening where people are saying, you know what, like, is this next treatment, is this next heart surgery, is this, this treatment procedure of dialysis, is this what I want? Is this leaving me in a healthy state? And so that is what kind of this number kind of looks at, like how health adjusted life expectancy. So during 2020, there was a lot of conspiracy theories that were running around, and people, I think people had a lot of time on their hands. We weren't really allowed to go to work or do the things we were normally doing. And I remember people saying things like, well, the COVID-19 isn't really a big deal because, and here using one of the terms I just talked about, there was no years of potential life lost, meaning, yes, COVID-19 was killing people, but those people were dying or would have died of something else, meaning they were going to die. It was just a matter of which disease was going to take them, and I was like, oh, okay, I don't know, maybe that makes sense. But what I did was I looked up at the CDC and I looked at the weekly number of deaths from all causes, right? And so because if people were going to die anyway of something else, then the total number of deaths shouldn't go up because they were going to die anyway. And so I looked here, and what I found was that what you can see, I don't know if you can see my markers, what you can see is that in May of 2020, you have a spike in the number of deaths, and then it kind of goes down. And that's kind of normal, because what you can see is kind of this is a normal kind of ebb and flow. By the way, where are the highest points? During the winter time. But you see a spike here in the spring, which doesn't make sense because the spring's kind of a low time normally. Here's the spring right there, and there's the spring right there. But here you have a spike, and then in January of 21, you have this massive sort of mountain of deaths here popping up. And so this is something that anybody can do to find this out, but obviously epidemiologists are probably going to do a lot more of it than the general population. And so yeah, so secondary sources of data, this data comes from the CDC. They obviously are collecting this data, and where are they getting this from? They're getting this from that previous chart we talked about, the clinics, the hospitals, the doctors, and then they're saying, this number of people died, this number of people were born, and then they're passing that on to the local health departments, who are passing it on to the state, who's passing it on to the CDC, which is then passing that on to the World Health Organization. So this is useful not just for making yourself feel better or disproving conspiracy theories, but for planning public health programs. Do you want to, as a community, spend money if there's not a need? And then what is that need? How do you know unless you are either doing the research yourself, which is expensive to do, or you're going to some other data source? So where are these sources of data? Well, there's a couple mentioned here, and one of them is the U.S. Census, and this is a massive project that's undertaken every 10 years by the U.S. government. It dates all the way back to the founding of our country, and it gathers information on who is living in the United States, and it asks things about race and age and income and education and who is dwelling with whom. And actually the U.S. Census Bureau actually collects data every year, but they try to get everybody at least every 10 years, right? And then there's a vital statistics report, which gathers information from a lot of different sources on things like who was born and who died and who got married, who got divorced. And this is published by the NCHS, National Center for Health Statistics, which is a part of the CDC. All right, when it comes to epidemics, you have to realize that throughout history, epidemics are very deadly and very scary for a population, especially a population that is very urbanized like ours. And because historically, epidemics could kill up to, half of a population. And so when you have an epidemic, and I know that the one, with COVID is kind of leaving, at least it's leaving our attention anyway. You want to understand what is going on, especially in the beginning when you don't really know how deadly it is and who it affects and things of that nature. You want to study it, and so this slide looks at studying epidemics and looking at who and where and when. So who is looking at the number of people who have been affected by it and who those people are, right? And when are they symptomatic, the onset of each case, and when are cases going up and when are cases going down, and where these people are living and where have they been that maybe relates to how they got this illness. So I just recently read a fictional book called The End of Men, and it was about a virus that only killed men, and it spread pretty quickly. And it, when it first kind of showed up, I think it showed up in Scotland, and men were coming in and they were hot, and they had they were like exhibiting flu-like symptoms, and then within a matter of a couple of days they were dead. And there was this study that had to be done trying to figure out what is going on, who is it affecting. Obviously it's affecting men, but it wasn't affecting every man. It was about 10% of men were immune to it for one reason or another. And then they wanted to know when people started showing symptoms. And so for this illness, it tended to be that they were showing symptoms about 24 to 48 hours after they were exposed. And where had they been? That was obviously very important, because if it originates one place and you can figure out where it came from, then that's really a clue to how to build a vaccine to prevent it, but then also about understanding how to prevent it from spreading. And unfortunately in the book, they didn't do a good job of that. They kind of dismissed the early cases of it and allowed people to hop on airplanes and buses and trains and spread it all through the world. So, all right, last slide here is about determining causation. And realize that saying that one thing causes another from a medical standpoint, from an epidemiological standpoint, is really a high bar. It is very difficult to prove that one thing causes another. Association or correlation does not imply causation. And you could think of a lot of silly examples of this. You could think about, does the fact that people don't walk on their lawns cause the grass to grow higher? And you could think about, well, no, that doesn't make a whole lot of sense, but you could think about, but there is an association between no one stepping on their grass and the grass growing taller over the next couple of days. And you're like, okay, but that doesn't necessarily mean that the association is the cause, right? And so you might say, well, let's think about rainy days. On rainy days, people aren't walking on the grass because it's raining outside, right? And then the rain, which is that third factor out there, actually is what causes the grass to grow, you know. And so how do you know that, say, well, cigarettes and tobacco smoking is what causes lung cancer? Well, it's taken a lot of research and a lot of years to establish that causal relationship between the two things. And that's based upon the strength of the association, you know. So it tends to be that, you know, if you smoke a lot of cigarettes for a long time, then you're much more likely to get lung cancer than if you don't smoke a lot or don't smoke a long time, right? So dose response, again, a lot of cigarettes, it's a more likely to get that. Consistency, specificity, temporality, meaning it shouldn't just be something that kind of comes up and maybe, you know, during a certain number of years, a lot of people get lung cancer and then goes away, right? And it should be biologically plausible. So what do we know about tobacco? What do we know about cancer? Is it possible that these two things could have a causal relationship? And so this is why it's taken us, you know, decades to establish that link between those two. And if you're cynical, you might think that it has something to do with the big tobacco fighting against that. So, all right, well, that is chapter 3.